policy specialist. And we are really excited to be able to host this training today. We have Chelsea Gilbert and Heather Fortune from the BICAP program and the Senior Services Engagement Program at the Richmond Area Agency on Aging, which is the Capital Area Agency on Aging there on the screen for Senior Connections. Just a little housekeeping. It is a long training. It goes till noon and we will have a break in the middle. We are also recording, so it will be posted. You likely already saw a pop-up that says it was recording. And then Ezra Halstead from VPLC is also here to provide some tech support. So feel free to chat them directly or put a question just to everyone in the chat if you do have any kind of issues or need any support in that manner. So at that, just thank you, Chelsea. Thank you, Heather. And I'm going to turn it over to you.
Thank you so much, Sarah. Again, my name is Heather Fortune. I am the Director of Support Services and Engagement here at Senior Connections. And Chelsea Gilbert is here with me. She is the Virginia Insurance Counseling and Assistance Program, or VICAP, manager here at our office. And she's actually going to get us started today. So thank you so much for having us.
Thank you, Heather. Hi, everybody. As Heather just mentioned, my name is Chelsea Gilbert. I am with Senior Connections and I am the VICAP manager. First, I wanted to give you guys a little bit of background information on Senior Connections. We are the designated area agency on aging for Planning District 15. This consists of Richmond and 7 of the surrounding counties. We are a nonprofit organization and we provide services, information and referrals, education and advocacy for older adults, caregivers, and persons with disabilities. You can learn more about us at our website at www.seniorconnections-va.org or by calling us at 804-343-3000. You can also find your local agency at www.usaging.org. All right, now more about VICAP. VICAP stands for the Virginia Insurance Counseling and Assistance Program. We are a part of a larger program called SHIP, and that stands for the State Health Insurance Program. VICAP counsels on all Medicare topics, as you can see here, including original Medicare, Medicare prescription drug coverage, Medicare Advantage plans, Medicare supplementals, which is your Medicaps, extra help, long-term care insurance, Medicare appeals and denials, and preventing, detecting, and reporting healthcare fraud. All right, so we also work collaboratively with the SMP, which is the Senior Medicare Patrol. We help educate and empower beneficiaries to take an active role in detecting and preventing their healthcare fraud. We always say protect, detect, and report. Always contact 1-800-938-8885 to report any suspected Medicare fraud. And you can also contact us as we, again, work collaboratively with the SMP and we can assist with any of that as well. All right. And we also encourage anyone to please protect their Medicare number as well. That is probably the biggest part of protecting yourself from Medicare fraud. All right, and we do also work with the BEC. We do have that program, which is our benefits enrollment program at Senior Connections. It did launch in 2019. We do have employees that will assist with the LIS, extra help applications, Medicare savings programs, Medicaid, SNAP, and energy assistance programs. You can contact the BEC by calling 804-3000, or you can email the BEC at bec@yourAAA.org. All right, now on to what Medicare is, what we're all here for. The first 2 parts are going to be your Medicare A and B. Medicare is going to be your federal health insurance program for individuals that are 65 or older. Individuals under 65 with disabilities receiving SSDI, or individuals with end-stage renal disease or ESRD. There are 4 parts to your Medicare. As I just mentioned, you're probably most familiar with your Medicare Part A and your Medicare Part B. Your Medicare Part A is your hospital insurance, and your Medicare Part B is your medical insurance. You can find both of those on your red, white, and blue card, which is right down here. As you can see a visual, that information is there for you to be able to provide to your insurance providers. Medicare Part C and Medicare Part D are optional. You do have the option of adding a Medicare Advantage plan to your Part A and B, or a Medicare Part D, which is your prescription drug coverage. And D stands for drug. All right. Okay, so original Medicare premium costs. So Medicare Part A, once again, that's your hospital insurance. Individuals that paid into Medicare taxes for 40 or more quarters will pay no monthly premium for Part A. That is referred to as your premium-free Part A. So anybody that has been paying into their taxes for 40 or more quarters would receive the premium-free Part A. Individuals that paid Medicare taxes for less than 30 quarters will pay $499 a month in 2022 for their premium. Individuals that paid Medicare taxes for 30 to 39 quarters will pay $274 a month in 2022 for their premium. All right, so your Part B. The standard Part B premium in 2022 is $170.10. Some individuals may pay a higher amount depending on what their income is. Individuals enrolled in Part B prior to 2022 may have a lower payment. The hold harmless rule protects you from having your previous year's Social Security benefit level reduced by an increase in the Part B premium, so long as you are entitled to Social Security benefits for November and December of the current year. The Part B premium will be or was deducted from your Social Security benefits in November through January. You don't already pay higher Part B premiums because of income-related monthly adjustment amount, IRMA, eligibility, and you do not receive a cost of living large enough to cover the increased premium. The COLA in 2021 was 1.3% of your Social Security benefit. Heather, do we know what 2022 is?
Yes, I'm so sorry. I just realized that we did not update that on that slide. Yeah, so let me pull that up really quick. I'm so sorry. That was definitely on me. I updated that slide and missed that. The cost of living adjustment for 2022. Oh, sorry. 5.9%.
All right, so 5.9% for 2022. So income related monthly adjustment amount, or IRMA. You will pay higher than the standard Part B premium if your modified adjusted gross income as reported on your IRS tax return from 2 years ago is above a certain amount. IRMA is an extra charge added to your premium. So this is going to be in addition to your premium. As you can see here on the chart, it tells you if you file individual tax return, et cetera, and what you would pay in each month of 2022. If you have had a major life-changing event and your income has gone down, you may use the SSA 44 form to request a reduction in your IRMA. All right, Medicare Part A, hospital insurance. I like to tell people, and I think Heather is a fan of this as well, Part A stands for ambulance. That way you can think of hospital whenever you think of your Medicare Part A. That deductible is $1,556 per benefit period in 2022. Medicare A, again, hospital insurance is going to cover inpatient hospital care. You do get days 1 through 60 at $0 each for any type of copay. Days 61 through 90 is $389 per day. Days 91 and beyond, $778 per each lifetime reserve day. So you do get up to 60 lifetime reserve days. Beyond your lifetime reserve days, all costs are the beneficiary's responsibility. So after those days max out, and there are no more days to utilize, all of the costs are now going to be on the patient, as well as any secondary insurances that they may have. A benefit period begins the day an individual is admitted as an inpatient in a hospital or SNF. Always, always, always check, contact the billing office, speak with anybody at the hospital or the SNF. Always find out when they counted you as inpatient, because that does matter as far as what they're counting for Medicare days. Oftentimes there can be discrepancies between a hospital or SNF, or whether it was inpatient or outpatient. So always do contact them. The benefit period ends when you haven't had inpatient or SNF care for 60 days in a row. So you can't go to the hospital, have any sort of SNF care for 60 days. And after that, everything will go ahead and turn back over. All right, Medicare Part A SNF coverage. So the SNF is covered in certain conditions for a limited time. So SNFs are typically short-term basis. And if you're wondering what a SNF is a skilled nursing facility. This is maybe a rehabilitation or skilled nursing that you're receiving after a hospital stay, or meeting certain skillable conditions. In order to be able to be covered under Part A at a SNF, you have to have Part A days left in the benefit period. So if there are no days left, you could be potentially cut, looking at more co-insurance, more copay days, things like that. So you have to make sure that you do have time left in that benefit period. Typically, you do require a qualifying hospital stay, which is typically 3 nights. Recently, during COVID, there has been a qualifying hospital stay waiver that has been in place during the public health emergency. So in those situations, a lot of the patients that were receiving skillable care, especially due to COVID, they were being able to use that QHS waiver to get out of the hospital and utilize their Medicare A benefits in a different form, which is in a skilled nursing facility. Your doctor must decide that you need daily skilled care, and it must be given by or under the supervision of skilled nursing and therapy staff. So that staff must be certified, must be a Medicare facility, and it must be stated that they do require that skilled care. It can't be long-term type 24-hour care. You get these skilled services in a SNF that's certified by Medicare. As I just mentioned, it has to be a Medicare facility. You need these skilled services for a medical condition that's either, and as I mentioned earlier, it would be after a hospital stay, or a condition that started while you were getting care in the SNF. So as I mentioned before, like with COVID, when people were getting that was a skillable condition, and it was allowing for that waiver. Okay, so there is a lot of confusion surrounding Medicare Part A and skilled nursing facility coverage. You do get days 1 through 20 at $0 copay. Once you hit that 21st day, it is $194.50 each day. This cost can be covered by secondary insurances such as Medigap or Medicaid. However, after your 21st day, you will incur that coinsurance. After your full 100 days that's given to you by Medicare has exhausted, all costs would then be onto the beneficiary. A lot of beneficiaries, a lot of patients that come in and out of skilled nursing facilities often do not realize that there is an end to that skilled nursing stay, and there is typically then a long-term care stay, which is covered by something completely different. So after those days have exhausted, that skilled stay does end. A benefit period begins the day an individual is admitted as an inpatient in a hospital or SNF. So again, same thing there. Once they're admitted into the SNF, that is when that benefit period begins. All right, so when you're in a SNF and you are coming to the end of your short-term stay, your services have been deemed by a provider or by the director of rehab and skilled nurses that you are now ready for a next level of care, meaning that there is not anything still scalable, anything for Medicare to still cover. At that point, a notice is then given to the patient or the beneficiary. So this is given when those services that they're receiving are no longer scalable, and allowing the patient to know that they now have an option. So their option at this point is to either end the services and move on to a next level of care, or the other option is to appeal that decision that was made. Once the 21st day is coming up, there is a 2 calendar day. So it's typically 72 hours before what would be considered a discharge date, or 48 hours from the day that Medicare would stop covering. This gives the patient or beneficiary a chance to review the information, speak with the QIO, and be able to submit this appeal. And that way they can reconsider whether or not that patient is still requiring any sort of skilled services, and it would then be the responsibility of the facility to keep that up and to continue. Or if the patient does not actually really require that type of care any longer, and so now they are ready to go ahead and have them move on to that next level of care. So those are the options that are given to that beneficiary. They're saying, hey, we can either work on this discharge for you, we can go ahead and get you ready for going home, going on to independent living, assisted living, any of those types of things, or we can go ahead and contact the QIO. So there are requirements on behalf of anyone that is delivering a notice of Medicare non-coverage to a beneficiary, especially in a SNF. But providers must deliver the NOMNIC to all beneficiaries eligible for the expedited determination process. A NOMNIC must be delivered even if the beneficiary agrees with the termination of services. So that NOMNIC is a huge part of the appeals process. It does indicate that the beneficiary has been notified that those services will then end. That way, they're able to go back and say, okay, Medicare knows that they have been notified, and now we can go ahead and move on. A lot of times when those types of forms are being signed by the beneficiary, they think they may be agreeing to end those services. It's just letting you know, hey, this has been told to you. These are your options. This is what you're able to do. Medicare providers are responsible for the delivery of the NOMNIC. They are able to delegate whomever will be delivering that message. Typically, it's going to be a social worker or like a business office director for a skilled nursing facility. It would probably be the same for a home health agency or something of that nature as well, just because they do have to ensure that whomever is signing the document understands that what they have been told and what they need to do. The provider must ensure that the beneficiary or the representative signs and dates the NOMNIC to demonstrate that the beneficiary or representative received the notice and understands that the termination decision can be disputed. Use of assistive devices may be used to obtain signature. So they do and will accept refusal of signing if there is a witness. They will also accept, X's or other signatures if there is appropriate documentation stating that that is okay. All right, appealing the NOMNIC. In order to appeal the NOMNIC, the beneficiary must contact the QIO. At times, things can get confusing, and that is why it's very important and why they choose to delegate this type of notice to a social worker or a business director so that they're able to actually explain the appeal process and what is going on. There are often other phone numbers there listed other than the QIO, such as the insurance company. The appeals must be submitted into the QIO, which is a quality improvement organization. For Virginia, the QIO is Levanta. The phone number is listed right here, 1-888-396-4646, and their fax line as well. They also have the option of any type of grievance or anything that needs to be stated as far as an appeal or grievance is concerned regarding Medicare. The beneficiary is given a time limit to appeal. So they are instructed by the staff that is providing the notice that they will only have until typically it's the next day around 12 o'clock to make that decision. Usually they're given that full 48 hours to be able to contact and provide that information to the appeal center. But if they do miss that timeline, they won't have that option to appeal. The staff will also provide information to their representative or beneficiary just to ensure that they're understanding what's going on and that they can provide assistance. But this is only if the beneficiary authorizes that person to be involved or they have some sort of documentation involving them. But again, that is oftentimes helpful in explaining the process and being able to move on to the next steps. Once the appeal is submitted to the QIO, on the patient's behalf, it is just a phone call. On the facility's behalf or the provider's behalf, it's submitting the medical records. At that point, once the medical records are sent over to the QIO, there is a medical reviewer that does complete the review of those medical records. Once they review the medical records, they're able to determine whether or not the services should be considered still scalable and still covered under Medicare. If the services were rendered correctly, those types of things are then reviewed. And then they do go back and let both the beneficiary and the facility or provider know in both writing and via phone call. That way there is no time wasted. The only thing that they do let everyone know in that NOMNIC where there is the discussion of the appealing process, it is also letting the beneficiary know that Levanta does have the right to take as long as they need to be able to review these records. So if for some reason the services continue past the date that is on the notice and the QIO has not gotten that review completed, the patient, if they do lose the appeal, could be responsible for those days. So that is something that facilities will often tell the patients so that they're not just sitting there waiting and potentially looking at not being covered. Medicare Part A and hospice coverage. All right. So Medicare Part A does cover hospice. So if you meet all of these conditions, you can get hospice care. Your hospice doctor, your regular doctor, can certify that you are terminally ill with a life expectancy of 6 months or less. So if you're terminally ill, there is some other criteria that you can meet other than having that 6 months or less in order to meet hospice needs. However, a lot of times this is the criteria that they base it off of. You accept palliative care or comfort instead of care to cure your illness. So you don't want to continue on with any sort of aggressive forms of treatment. You sign a statement choosing hospice care instead of other Medicare covered benefits to treat your terminal illness and related conditions. So oftentimes doctors will go ahead and assess their patients for whether or not hospice is appropriate. They will often do what is called an evaluation and treat and go ahead and speak with the family, speak with the staff to determine whether or not that patient is going to be appropriate for hospice care. Once that's been completed, then the patient is admitted over to the hospice company. Hospice is a wonderful program because you don't pay anything for that hospice care. It is covered by your Part A. You may need to pay a copayment of no more than $5 for each prescription drug and other similar products for pain relief and symptom control while you're at home. In the rare case your drug isn't covered by the hospice benefit, and it is a rarity, your hospice provider should contact your Medicare drug plan to see if it's covered under Part D. You may need to pay 5% of the Medicare approved amount for inpatient respite care. A lot of confusion surrounds respite care on what is considered respite care. Respite care is considered when the caregiver or the company needs some time and that patient does need care provided outside of their normal caregiving. Inpatient respite care is typically in a skilled nursing facility. And that is typically just like a 5-day stay. Medicare doesn't cover room and board when you get hospice care in your home or another facility where you live, like a nursing home. So a lot of times there is a misconception of, Medicare A pays for those room and boards. They pay for everything because you've got hospice. That is absolutely not true. Medicare does not cover room and board. So something like Medicaid or private pay, or in some cases, hospice will also do charity cases, depending on the situation. So those are the types of things that would have to cover room and board. Medicare A is only going to cover those services. All right, Medicare Part A home health coverage. When you say Medicare Part A in the home health world, they all go, woo, that's awesome. They love Medicare Part A. Medicare Part A and Part B cover eligible home health services. A lot of times you're not going to find that Part A is not going to cover home health. They cover part-time or intermittent skilled nursing care. You are not eligible if you need more than part-time or intermittent skilled nursing care. So Part A is only going to cover a few hours for a few days a week. Whatever you're evaluated at is what you will be able to have covered. If there is longer term needs like 24-hour care, that is not something that's going to be covered by Medicare. That would then have to be covered by something like Medicaid or private pay, something like that. But there will not be a time where Part A will cover more than just some intermittent or part-time nursing care. For physical therapy, your Part B is going to cover your therapies. So Part B covers physical therapy, occupational therapy, speech language pathology services. And then Medicare will also cover medical social services. So anybody to assist with continuing Medicaid applications, to assist with finding potential caregivers in the home, those types of things. And then part-time or intermittent home health aid services. Again, this is the same thing as the nursing piece. They will provide temporary and only for a few hours a week And typically it's under like a bridge to home program, meaning that you are only going to be using those services temporarily and then move over to something more permanent, such as a family member or an actual service. Medicare Part A is never going to pay for 24-hour care for personal care services either. Again, Medicare doesn't pay for 24-hour-a-day care at home. It doesn't pay for meals delivered to your home, homemaker services. So anything involving any of that personal care, custody or personal care, again, bathroom needs, anything like that. So those things all have to be covered by Medicaid, and also, you know, different qualifications there as well. All right, so your ABN, your advanced beneficiary notice. So these go along with your NOMNICs, and your NOMNICs, as we just mentioned, are given out by your skilled nursing facilities, as we ran through your home health agencies, hospice, etc. Typically in a skilled nursing facility, the ABN, which is your advanced beneficiary notice form, is issued. Again, it's issued by all of those types of providers. But in this situation with skilled nursing facilities, they will go ahead and let you know when Medicare payment is expected to be denied. So this is just slightly before your NOMNIC comes in, and a lot of times skilled nursing facilities will give them together. Agencies such as home health or hospice, they may give those beforehand. Just to give the heads up, typically with a skilled nursing facility, things are set off of the utilization review meetings. And so therefore, a lot of times those things kind of go hand in hand when they find out about that potential discharge date. So the ABN just lets the patient know that they need to expect that if they make this decision and they decide not to appeal, if they decide to not move any further and sign off on the document, that they are agreeing to either A, discharge from the facility or discharge from the services, or B, that they are looking to continue them and potentially pay out of pocket for that. So it does often state how much money per day that would be after the Medicare payment is expected to be denied at that point. So meaning that they're expecting that those scalable services will no longer be needed after such and such date. And so they're, you know, letting the beneficiary know, hey, you're going to get a notice. It's going to let you know that you have an option to appeal. You have an option to stay. But once that ABN form is signed, it is letting the provider and anyone else know that, you know, financial responsibility is now taken on by the patient, and they have signed that. All right, Medicare Part B, medical insurance. So the deductible for Medicare Part B is $233 per year in 2022. So co-insurance, that's typically going to be 20% of the Medicare approved amount for most services. So that's going to include your doctor's services while you are hospital inpatient, because physicians are often paid off of the Medicare Part B. It's $0 for most preventative and screening services if your physician accepts the Medicare assignment. So if your physician accepts Medicare assignment, your preventative screenings should be free. You also want to contact them though, because there are limits to how often they're covered. So you just want to make sure that, you know, you're getting one flu shot per flu season if, you know, it's only covering one time. All right, Medicare Part B preventative screening services. So as you can see here, there is a list of those services. Bone mass measurements, cervical and vaginal cancer screenings, depression screenings, glaucoma tests, one-time welcome to Medicare preventative visits, and then of course your shots. We now have the option of COVID-19 vaccines to be covered by Part B, your flu shot, hepatitis B shot, your pneumococcal shots, all of those things can be covered by your Part B. All right, so in case all of that was a lot and you cannot remember everything, which we all cannot, we do have this option of a Medicare What's Covered app. I definitely recommend to go ahead and download the Medicare app. It is free. It allows you to quickly see whether your services are covered. That is something that could be very beneficial in finding out before you even have to get to that point. Or if you're unsure that you're given the right information at the provider that you're at, you can always double check it there. It is available on both the App Store and Google Play. So it does have options on both iPhone and Android. It does provide general cost, coverage, and eligibility details for items and services covered by Medicare Part A and B. You can also go to medicare.gov/coverage. Really, you can find pretty much anything on medicare.gov. But you know, it's a large website. So if you want something a little more streamlined, you can download the app and would be able to find that information there. All right, one of my favorite things in the world, Medicare summary notice. So a lot of people will get a Medicare summary notice in the mail, and they will look and they will say, don't need this. This is junk. It says it's not a bill. It is not a bill, that is for sure, but you do still need it. It is a notice that people with original Medicare get in the mail every 3 months for their Medicare Part A and Part B covered services. So the MSN, it's going to show you all your services or supplies that providers and suppliers billed to Medicare during the 3-month period. So this is going to give you the ability to look and see, okay, did I get these services? Did I get these supplies? Was this given to me during this time? And what was billed to Medicare? This way you can see exactly what the provider is sending out to them. It will also show what Medicare is willing to pay. And then it will also show the maximum amount that you could potentially owe to the provider, so that you can look to see, hey, maybe I didn't provide, my secondary information, or why isn't this covered? It gives you the opportunity to really look into that information and discuss it with the provider. If you find that you have questions about your MSN, definitely contact the provider. You never know, if there's always human error, there could have been an issue. Contact the provider, find out exactly what's going on, and always check for those mistakes. It's very important that you do so. If you don't get any services or medical supplies during that 3-month period, you're not going to get an MSN. So you wouldn't get one unless you did receive the services. So that means it's even more important to keep these around and review them. Right. With all of that said, to move on to what do you do to get signed up? How do you get Medicare? How does this work? So initial enrollment period, or your IEP. So individuals turning 65, original Medicare enrollment is automatic if you're turning 65 and receiving Social Security or railroad retirement benefits. So if you're receiving Social Security, railroad retirement benefits, you're probably going to get a Medicare card that's going to be mailed out to you, because you're going to be automatically enrolled into this program. If you are not already enrolled in Social Security or railroad retirement benefits, you have the 3 months before, the month of, and 3 months after to enroll in Medicare after you turn 65. You do not want to wait on these types of things. So if you are not already enrolled in Social Security or railroad retirements, and you're not going to be automatically enrolled in Medicare, you definitely want to go ahead and get onto that during that 7-month period. It's very important. If an individual wants to enroll into a Part C or a Part D, which, as I mentioned earlier, those are optional to add on for your Medicare A and B. So you've got to have your Medicare A and B first. You must enroll during the IEP for Part C and Part D as well. So you'll have a total of 7 months, which includes the 3 months before, the 3 months of, and the 3 months after you turn 65. Now, for individuals receiving SSDI or Social Security Disability, original Medicare enrollment is automatic after 24 months of receiving disability benefits. So once you have received 24 months of disability benefits, your coverage is going to start on the first of the 25th month you receive disability payments. Individuals diagnosed with ALS are eligible for Medicare the first month they receive disability payments. So immediately upon receiving those disability payments, anyone with ALS is automatically eligible for Medicare after that disability payment. If an individual wants to enroll into Part C or Part D, you must enroll during the 7-month period that includes 3 months before your 25th month of receiving disability payments, the 25th month, and the 3 months after your 25th month. So not too much different. And again, can't add that C and D unless you have that A and B. So very, very important that if you are not under any of this criteria for, having Social Security benefits, railroad benefits that will automatically enroll you, or having the SSDI that will automatically enroll you, you want to make sure that you take advantage during that 7-month period that you have to enroll to go ahead and enroll. Now, if you missed that and you are in a different situation, and you need to take advantage of a special enrollment period, they do have those options. That is only going to be if you and your spouse is working and you're covered by a group health plan, or it's after 8 months of your group health plan ending. So after your Part A and Part B, after your 8 months, you have that time to sign up for your Part A and your Part B. Also, if you're an international volunteer and were out of the country during your initial enrollment period for at least 12 months on behalf of a tax-exempt organization and had health insurance that provided coverage for the duration of the volunteer services. Believe it or not, that sounds like a crazy situation that may not happen, but it actually does and has happened. Actually, I've heard of it happening here recently. So you do have a 6-month special enrollment period to sign up for Part A and B when you are no longer serving as a volunteer outside of the US. The organization no longer has tax exempt status, so they are no longer tax exempt. And you no longer have health insurance that provided coverage outside of the US. So it's whichever one of those happened first. So again, with your first one, if you're on an employer insurance, you're covered by a group health plan, or your spouse is, you have an 8-month special enrollment period to sign up for Medicare A and B. If you're outside as an international volunteer and you're outside of the country, during the initial enrollment period, you'll have a 6-month special enrollment period to sign up for Part A and B when you meet the criteria for that. All right, and a general enrollment period. So we had your initial enrollment period, your special enrollment period, and now you have your general enrollment period. A lot of enrollment periods. What is your general enrollment period? So that is going to be your annual window for Medicare recipients to enroll in Part A or B. So again, as I mentioned before and expressed the importance, if you're not going to be automatically enrolled and you're not going to be able to make it within those 7 months that you do have, you don't fit a special enrollment period, you don't enroll, you could be looking at late enrollment penalties for Part A or B if you choose to enroll outside of those periods. When is the general enrollment period? That's going to be January 1st through March 31st. These changes do take effect on July 1st. So anything that is changed between that January 1st and March 31st will not be reflected until after July 1st. Additional opportunities to enroll in Part C or Part D. If you have Part A and enrolled into Part B during the general enrollment period, you can enroll into a Medicare Advantage plan April 1st through June 30th. So again, if you have Part A already and you enrolled into a Part B during the general enrollment period, you can enroll in a Medicare Advantage plan during the April 1st to June 30th period. If you do not have Part A and enrolled into Part B during the general enrollment period, you can enroll into a Medicare prescription drug plan April 1st through June 30th. All right, late enrollment penalties. So again, as I've mentioned before, you do not want to run into these if you can help it. For Medicare Part A, if you aren't eligible for premium free Part A and you don't buy it when you're first eligible, so you don't have those 40 quarters of taxes and you didn't buy it during any of those enrollment periods, you're probably going to be subject to a late enrollment penalty. That penalty is going to be 10% of the Part A premium. The length of time you pay this penalty is going to be twice the number of years you could have had Part A but didn't sign up. So as I mentioned before, super important to sign up because again, you're penalized for any amount of time that you have that gaps in between that. So you want to definitely make sure that you're paying attention. Medicare Part B. If you did not sign up for Part B when you were first eligible and you are not eligible for one of the special enrollment periods, you will have to pay the late enrollment penalty. So again, that's going to be 10%. And that's of the Part B premium for each 12-month period you could have had Part B but didn't sign up. That length of time is going to be as long as you have Medicare Part B. If you are under 65 and enrolled in Medicare, you will no longer have to pay the penalty once you turn 65. All right, signing up for Medicare with end-stage renal disease. You can get Medicare no matter how old you are if all of these apply. So this is directly dealing with end-stage renal disease. Your kidneys no longer work, you need regular dialysis, or you had a kidney transplant. One of these applies to you. So you've either worked the required amount of time under Social Security, railroad retirement, or as a government employee. You're already getting or are eligible for Social Security or railroad retirement benefits. You're the spouse or dependent child of a person who meets either of the requirements listed above. You can enroll in Part A and Part B by visiting your local Social Security office or by contacting Social Security at 1-800-772-1213. So if any of this applies, you can apply, you can go ahead and enroll for Part A and Part B by visiting the Social Security office. You will need both Part A and Part B to get the full benefits, as Medicare needs these different A's and B's to be able to pay for all the full scope of services. So it needs to be able to cover, dialysis, but also transportation to dialysis. It also needs to be able to cover kidney transplant services and anything that entails there. All right, Medicare based on end-stage renal disease coverage start. So Medicare coverage usually starts on the first day of the 4th month of your dialysis treatment. So on that first day of your 4th month of your dialysis treatments, that's when the Medicare coverage is typically going to start. That waiting period will start even if you haven't signed up for Medicare, which is great. Medicare coverage can start as early as the first month of dialysis if you meet all of these conditions, because dialysis is such a big thing. There are so many moving parts to that, you know, with transportation and all of that. So if you meet all of these conditions, it can start right away. So you take part in home dialysis training or peritoneal dialysis program offered by a Medicare certified training facility to teach you how to give yourself dialysis treatments at home. Your doctor expects you to finish training and be able to do your own dialysis treatments. The regular course of dialysis is maintained through the waiting period that would otherwise apply. All right. If you have Medicare only because of permanent kidney failure, Medicare coverage will end 12 months after the month you stop dialysis treatments or 36 months after the month you have a kidney transplant. So if you only have Medicare because of the permanent kidney failure, again, that Medicare coverage will end after that time. As there won't be any dialysis to continue. Your Medicare coverage will be extended if you go back to using dialysis again, or if you get a kidney transplant within 12 months after the month you stopped getting dialysis. Or if you start dialysis or get another kidney transplant within 36 months after the month you get a kidney transplant. All right, Medicare Advantage and InStage renal disease. InStage renal disease beneficiaries are permitted to enroll in a Medicare Advantage plan. So InStage renal disease beneficiaries can sign up for a Part C, and they can fall under any of the plans there, such as, the Aetna's, Humana's, United Healthcare's, Molina's, etc. So they would be able to enroll into one of those programs. Prior to January 1st, 2021, InStage renal disease could rarely enroll into a Medicare Advantage plan. So this is something that has just began. All right, if you have questions about enrollment, we encourage you to definitely visit your local Social Security office. I know with COVID and other regulations, things have changed a little bit, but I do believe they are back open for appointments. You can also contact Social Security directly at 1-800-772-1213. If you have any questions or you need any assistance, plan comparisons, counseling, etc., we are happy to help and give you information about those things. We cannot sign you up for Medicare, so you do have to contact Social Security. There's really no way around that piece of it unless you were automatically enrolled. There is a website for Social Security. It's www.ssa.gov. You can get on their website. There's also local Social Security offices and phone numbers there as well. Again, BICAP can definitely help answer any questions regarding any of these things. You can reach us directly at 804-343-3014. Or you can always, if you're outside of our local area agency on aging, you can contact 1-800-552-3402 in an effort to be able to get in contact with yours. Does anyone have any questions so far? Yes.
Does area of agency sign people up for Medicare, or they just give them the information that they need?
We're just going to be providing information. In an effort to sign up for Medicare, you would need to contact Social Security.
What I meant is by not the regular Part A and Part B, but Advantage or supplemental.
Sure. So we can definitely help guide you with that prescription drug coverage or your Part D, but your Part C, you would need to contact those plans directly in order to sign up.
This is Heather. We are going to cover the Part D and Medicare Advantage, but our counselors are trained and certified and able to provide that unbiased assistance when it comes to selecting a Part D or Part C plan. And we do have access and resources to assist with that enrollment. So we can make a phone call to Medicare. We can assist with walking through the enrollment online via medicare.gov. So there are resources for us to assist someone with that process when it comes to Part C and Part D.
Oh, hold on, I'm pressing the button. All right, there we go. Wait. Heather, are you unable? Okay, thank you.
Okay, I have a quick question. To
Sure.
enroll for Medicare, do you have to be certified to help someone enroll?
Yes. So all of our counselors at BICAP are certified.
Okay. And how do you get the certification?
Heather, do you want to go over that part?
Yeah, that's a great question. So we can certainly help caregivers or advocates if you're working with someone and you want to be able to assist those individuals. We at BICAP can certainly help you through that process. But if someone wants to actually be a BICAP counselor, there's a training process that all of our counselors go through. It includes an online training as well as one-on-one training time. And then it requires taking an exam. Not only do you have to take an exam to first become certified, but then you have to take an exam every year after that to remain certified and to provide counseling. But that is specific to BICAP. So if someone wants to volunteer with BICAP, which most of our counselors, at least in our office, are volunteers. Every BICAP office is set up a little bit differently. Some BICAP offices have many volunteers like we do, and others have very few, and it's mostly just a couple of staff that might be providing the counseling. But either way, whether someone's staff or volunteer to BICAP, they have to take the exact same certification. If you're just generally looking for guidance and assistance to help a loved one, someone that you're working with as an advocate, that's something that we can help you with as well. We can work with caregivers.
All right. Any other? Oh, okay.
How about if we are a company, but we don't want to be an advocate for VICAP, but we want to get certified in order to help our patients enroll for Medicare? Because a lot of time we have patients that we're dealing with a lot of 65 and older patients, but we cannot enroll them into Advantage or Part Part D. But we have to advise them to go to somewhere else for somebody that's certified. So how can we get certified just to help the patients out?
So that's a great question. So I will say, if you are interested in going through the training and certification process, that would be done with your local VICAP office. So if someone was in Richmond or the 7 surrounding counties and they came here to Senior Connections and said, hey, I work with clients, who are 65 and up or under 65 with disabilities, and I'd like to be able to further assist them. There certainly is training and guidance that your VICAP office could provide. Now, if you're doing that as a part of your day-to-day job, you don't necessarily need to be certified yourself. you'd have to be certified to do it as BICAP. But if you're doing it in your job somewhere else, you don't necessarily have to have that certification. We could provide you the training and the support so that you know and understand what someone needs to go through to get enrolled in Medicare. So whether they're doing that through their myssa.gov account online, and you're just assisting them through that process if they're doing it on their own account, or if you want to further understand the steps on how to help someone do it over the phone, you would not, even if you're certified, you could not call Social Security and do that for someone. You could help someone through it, whether you're certified or not. So your local BICAP office could help you understand and go through the training to understand how to help someone through that. And you wouldn't necessarily have to go through the full certification process. So if you're in our area, I would encourage you to connect with Chelsea, because certainly that's a training that we have gone through with people in the community who don't necessarily want to volunteer or be certified, but they want to have the skills to help others through the process. That's something that your local BICAP office should be able to work with you on.
Absolutely. And if you're a part of ours, I'd be happy to come out and do outreach, one-on-one counseling, anything that we can do to potentially assist in better understanding and educating. All right, any other questions?
So we're going to go ahead and just take a 5-minute break. We are about halfway through the presentation, so we could certainly end up finishing up early. It just depends. We still are going to go through Medicare Part D, Medicare Advantage, Medigap, and cost savings programs. So let's go ahead and take a 5-minute break. I have that it's 10:05, so let's come back at 10 after, and we'll pick back up with Medicare Part D. If everyone's back and we can get rolling again. I hope everyone can see my slides now. I am now sharing my screen, so if there's a problem, just let me know. But I'm going to go ahead and let's see. Sorry, I'm just checking the chat. Okay, so there's a question in the chat regarding, I believe it was related to the Medicare summary notice, and that you get a Medicare summary notice quarterly if you've received services in that 3-month period, and how important it is to check that notice, because not only does that notice show what original Medicare was billed, you want to make sure that they were billed for the right things and you did in fact receive those services. But it also shows what they paid and what you may be responsible for. And you want to make sure that what Medicare says you may be responsible for matches what you're being billed, right? We've certainly seen instances where someone's Medicare summary notice said they were not responsible for a service or an amount, and they were billed anyways for it, right? So that's why that's so important. But the question that's here in the chat is there something similar for Medicare Advantage and Part D? And yes, there is. It's an explanation of benefits. And we are going to talk about that when we talk about Part D and Medicare Advantage plans. So thank you for that question. We'll stop before we move on to Medigap, so we can talk about any questions that come up about Part D and Med Advantage. Okay, wonderful. So Medicare Part D, this is your drug coverage. Unlike original Medicare, there is no standard premium for Part D, right? We talked about how for Part A, there's standard premiums based on if you've paid Medicare taxes for 40 or more quarters or not. For Part B, there's a standard premium for everyone, unless you are subject to IRMA and you have higher income, you might pay more than the standard. But nonetheless, that it's pretty standardized for original Medicare. But for Part D, premiums really do vary. The premiums right now start at around, I think the lowest one is $7 and some change in our area right now, and they go all the way up to $80 or more. So the premiums are going to vary widely with Part D plans. Just because a plan has a higher premium does not mean that it's a better plan. I want to, make sure folks understand that because sometimes on the individual or group market, we assume that the more expensive plans are the better plans, right? And oftentimes that's true, but that's not always true when it comes to Part D and Medicare Advantage, and we're going to talk about that. So while the premiums do vary for Part D, there is a standard structure as to how Part D is set up. So Part D plans may or may not have a deductible. The most the deductible can be right now is $480. A plan could have a deductible of $480, and it might have no deductible, or it might have, it might have a deductible somewhere in between. So there may or may not be a deductible tied to your Part D plan. And once you've met that deductible, if you have one, there's a standard structure where you have an initial coverage level, a coverage gap, and a catastrophic coverage level. And again, this is the same for all Part D plans. In your initial coverage level, this is where you are once you've met your deductible, if you have one. If you don't have a deductible, you start here. During the initial coverage level, you can pay up to a 25% coinsurance for your medications. That's both for your brand and your generic medications. Now, many plans provide an enhanced benefit and don't follow the standard 25%. So for many people in this initial coverage level, they're not paying a 25% coinsurance for all of their medications. It's usually tiered, and you may be paying just a flat copay. So for example, maybe in your initial coverage level for a preferred generic, you're going to pay $7. For a brand name medication, maybe you're paying $25, right? Each Part D plan sets that up a little bit differently, but you stay in your initial coverage level until the total amount paid out between both you and your plan reaches $4,430 this year. It's important that folks understand not everyone will get past the initial coverage level. It is based on what medications you're taking and how expensive they are and how much you and your plan are spending on your medication costs. Some people see this number and they're like, oh my goodness, I could never afford that. But it's really based on the individual and what you're prescribed, right? So if the total amount of your medications reaches that $4,430, you will leave the initial coverage level and go into the coverage gap, which was formerly known as the donut hole. The donut hole has now been closed as of 2019, but there's a lot of misconception around what that means. I've heard it said that the donut hole being closed means that you no longer have to pay anything in that coverage level, and that's just not true. The donut hole being closed means that you're no longer paying a 67% coinsurance when you get to the coverage gap, a 45% coinsurance when you get to the coverage gap. It used to be that when you got to this coverage gap, your costs went up from 25% to much more. But now they've closed that gap, meaning that the most that you will pay in the coverage gap, or what your coinsurance is in the coverage gap, is 25%. That is the same as the most that you will pay in the initial coverage level. So it doesn't mean that someone isn't going to feel the effects of going into this coverage level, because you certainly can still, especially if in the initial coverage level, you have that enhanced benefit, that flat copay that you might be paying. Once you hit the coverage gap, you are going to be charged that 25%. So it doesn't mean that you don't pay anything now in the coverage gap. It just means that they've capped it at 25%, which is the same as the cap in the initial coverage level. But beneficiaries still feel the effects of this. So likely if someone comes to us and says, hey, I was paying a flat copay for my drugs, and now I'm going to the pharmacy and they're telling me that it's going to be $200. What has likely occurred is they've likely gone into the coverage gap, right? So in this coverage level, you're going to pay a 25% coinsurance now for both your brand and generic medications. But how those costs are applied to getting out of the coverage gap is different for brand name medications and for generic medications. So for your brand name medications, 95% of the cost of the medication is going towards getting you out of the coverage gap. So that's including the 25% that you're paying plus the 70% manufacturer discount that you're getting. There's a 5% that your plan pays, and that does not go towards your true out-of-pocket and getting you out of the coverage gap. Now, for generic medications in the coverage gap, you also pay a 25% coinsurance, and only that 25% goes towards getting you out of the coverage gap. Once the total amount that is calculated and counted, which is your true out-of-pocket cost, reaches $7,050, you would leave the coverage gap and go into the catastrophic coverage level. And again, I want to point out that this is all based on spending for medication. So not everyone will go into the coverage gap, and not everyone who goes into it will come out of it. Okay. It all depends on how expensive your medications are. Now, if someone has a specialty medication, you can assume that that person is definitely going to be going through these coverage levels because of the high cost of that medication. But if someone's just on a couple of generics or a couple of brand name medications, they may never see the catastrophic coverage level. Once you get there, though, your costs are going to go down. And the catastrophic coverage level for your brand name medications, you are going to pay no more than 5% or $9.85. And for your generic medications, it's 5% or $3.95, whichever is higher. And if you get to the catastrophic coverage level, you stay here for the rest of the calendar year. This always starts over in January. Now, just like with Part B, the income-related monthly adjustment amount also applies to Part D. So earlier, Chelsea talked about the standard Part B premium and how some people with higher income levels are going to pay more than the standard. And it's the same for Part D, where if as an individual, if you make more than $91,000 a year. And if you're filing jointly, it's more than $182,000 in a year. You're actually going to have this additional amount tacked on to whatever your Part D premium is. So for whatever plan you enroll into and whatever that standard is, you're going to pay this additional amount. Now, it is important to note that they're looking at your taxes from 2 years prior. And that's really important, right? Because incomes change. Someone may retire and now they're on a fixed income, and what was reflected on their 2020 tax return is no longer accurate. So life events do occur, and there's a form that someone can fill out to request a reduction in their IRMAA if it's applicable. So if someone has gone through a divorce or retired, or their income is no longer what it was 2 years prior, you'd want to fill out that SSA 44 form to request that reduction in both the IRMAA related to your Part B, your medical, and your Part D for drug. Okay, so now we're going to talk about Medicare Advantage, or Part C. C stands for complete, and that's because these plans typically combine your hospital, your medical, and your drug all into one plan. Now, while they usually include drug coverage, they don't always include drug coverage. There are Medicare Advantage plans that do not include Part D. Just like Medicare Advantage plans that do, the premium costs are going to vary. There's an out-of-pocket maximum on those plans, but in some cases, you cannot add a separate Part D to a Medicare Advantage plan that doesn't include it. So that means that it's really not for everyone, right? If you need drug coverage, you don't want to enroll in a Medicare Advantage plan that doesn't include that and doesn't allow you to add it. So oftentimes those Medicare Advantage plans that don't include drug coverage might be good for someone who already has a separate drug plan, either through an employer, retiree coverage, or some other type of creditable drug coverage, and they're really just looking to enhance their medical benefit. But for most people who are looking at Medicare Advantage plans, they're looking at the plans that do include drug coverage. So for these Medicare Advantage plans with prescription drug coverage, the premium costs vary, and they start at $0 a month and go all the way up to $100 or more a month. When you hear those ads on the radio or on the TV saying, we're going to give you dental, vision, hearing, and we're going to throw in some transportation, all for $0 a month, that is always a Medicare Advantage plan. There is no $0 a month Part D plan. They are always, when they're promoting that, talking about these Part C plans. And again, as I mentioned earlier, while the costs vary widely from $0 a month to $100 or more a month, it doesn't always mean that the more expensive plan is better for the individual. When you're looking at Medicare Part D and Medicare Advantage plans, you're looking at each person and what their needs are. What prescriptions are they prescribed? What pharmacies do they go to? Who are their providers that they need to be able to access? And it might be different for a spouse or for family members, neighbors, relatives. Too often we hear, oh, well, my best friend has this plan and it seems to be great for her. So I think I want to go with that plan too. It's not like group and individual plans where we're all on the same plan and it just works well for everyone, right? It really is so specific to your needs. So if your best friend has a plan that works great for them, but your best friend has diabetes and you don't, then that plan might work better for someone who has diabetes. But what medications are you taking? What are your needs? That's always what we should be looking at when we're looking at these Part C and Part D plans. Under the Medicare Advantage plans, again, premiums are varying. And there are out-of-pocket maximums provided under these plans for health benefits only. So the out-of-pocket maximum does not apply to the drug benefits under a Medicare Advantage plan, but we look at this out-of-pocket maximum like a safety net, right? You don't anticipate spending $7,500 on medical costs for the year, but if some catastrophic event were to occur, that out-of-pocket maximum is going to catch you, right? It's your safety net. At some point, the bills will stop if you end up incurring high medical costs. So that's what we look at that as. And original Medicare itself doesn't have an out-of-pocket maximum. So earlier, how Chelsea talked about that 20% coinsurance you pay under Part B for most covered services, you pay 20% of everything always. It's not going to stop unless you have a secondary or something else. So again, the out-of-pocket maximum provided under a Medicare Advantage plan, we look at it as a benefit and really as a safety net. Medicare Advantage plans have to cover all of the same services as original Medicare, except for hospice care. Regardless if you have a Medicare Advantage plan or original Medicare, hospice care is always covered under Medicare Part A. Now, while these Advantage plans have to cover all of the services that original Medicare covers, they have their own coverage rules, right? So that's not going to always line up with original Medicare. So it's really important, again, when you're looking at these plans, that not only are you understanding what can be covered, but what are the rules and restrictions behind that coverage. So if someone has a Medicare Advantage plan, Medicare will no longer process their medical and health benefits. All payments have to go through that Medicare Advantage policy. And that's really important because when you're looking at a Medicare Advantage plan, they have their own networks of providers that you oftentimes have to stay within if you want coverage. So we get the question sometime, well, this doctor that I need to go to isn't in network with my Advantage plan. Can't I just give them my original Medicare card? And the answer is no. Once you've selected that Advantage plan, that is who all payments are going through. Unless you disenroll from that plan and switch back to original Medicare, you are not using your original Medicare card when you go to receive services. You are using that Medicare Advantage plan, and you can't just decide, which card you're going to give at that time. These Medicare Advantage plans are contracting with Medicare to provide you your coverage and services. Additionally, if you enroll in a Medicare Advantage plan, you still have to pay your Part B premium. Yes, all payments are going through that Medicare Advantage plan, but in order to even be eligible for Medicare Advantage, you have to have both A and B. So you have to maintain that Part B in order to even qualify to be in the Medicare Advantage plan. As a side note, when we talk about Medicare Part D as in drug, you only have to have A or B to enroll in a prescription drug plan. So you can have A or B and get a Part D plan. But in order to have Medicare Advantage, you have to have both A and B. Okay, so then what is the advantage of a Medicare Advantage plan? For many services under your hospital and medical coverage, you're going to have lower flat co-payments to visit your primary care, your specialist, the emergency room. So for example, you may have a $10 copay to your primary care, and you may have a $40 copay to see a specialist. Oftentimes, that's a lot less than the 20% that you would otherwise pay for just Medicare alone. And for some people, that's a really important benefit, right? They are concerned about, keeping those co-payments and those out-of-pocket expenses on a monthly basis to a minimum. So this could be a good option for someone who needs a low premium and also wants to cap those out-of-pocket costs. Additionally, as I mentioned, these plans provide an out-of-pocket maximum, which is not something that original Medicare itself has. When you're paying your original Medicare deductibles and your copay days for hospital and SNF and your coinsurance for Part B, you're going to pay that whatever the standard coverage is all year. But under a Medicare Advantage plan, the highest and out-of-pocket maximum can be for in-network services is $7,550. If you have a plan that allows you to go out of network, like a PPO, the highest the out-of-pocket maximum can be for in and out of network services is $11,300. Again, this is the maximum that the out-of-pocket maximum can be. There are plenty of plans that have a lower out-of-pocket maximum than that. So if it's really important for someone who knows that they have a chronic health condition or something that is going to require them to incur lots of medical expenses, maybe they need to keep their monthly premium low, so they know that they want a Medicare Advantage plan because that will do that. They might look for a plan with a lower out-of-pocket maximum. Someone who knows I'm definitely going to meet this because I get infusions or, something else that might be really important to that individual. So again, it's all very individualized, what we're looking at. As I mentioned, many plans do not allow you to go out of network when it comes to Medicare Advantage. So it's really important to pay attention to that and to pay attention to your provider network when enrolling into these plans. You want to check with your doctors before enrolling to make sure that you can access those providers, because if not, that could mean that you have no coverage to see those providers. So it's really important to look into that. And then additionally, these plans also can offer these additional benefits, or they call them supplemental benefits, which can be kind of confusing for it to be called that. These are things like dental, vision, hearing, etc. This is what is so heavily marketed, is these added benefits that Medicare Advantage plans can provide. It is so important to understand that while these benefits are really great, it is not the focus on why you're selecting a Medicare Advantage plan. When you're going into selecting a Part C Medicare Advantage plan, you want to really be focused on what are my health needs? What are my prescription needs? That is first. And only once you know that a plan is meeting both your health and prescription needs, would you then want to pay attention to these additional benefits. It's great if a plan offers you silver sneakers, but if you enroll into a plan only because it offers silver sneakers and you can't go see your specialist, now you're missing out on your medical care so that you can have silver sneakers, right? That's not worth it. So it is so important that the focus of your selection when it comes to an Advantage plan really remains to be your medical needs first. Now, when it comes to prescription coverage under Medicare Advantage, there is the exact same structure as what we have already discussed. That is, you may or may not have a deductible. And if you have a deductible and you've met that, or if you don't have a deductible, you are in your initial coverage level. From your initial coverage level, you have your coverage gap and your catastrophic coverage level. Again, the out-of-pocket maximum does not apply to your Part D prescription benefits under a Medicare Advantage plan. Now, as I kind of had mentioned, there are a couple different types of Medicare Advantage plans. The first one being your HMO. Many people are familiar with some of these terms because it's the same terms that you would hear when you're talking about a group or individual plan. HMOs or health maintenance organizations, these are typically the most restrictive plans. Oftentimes you have a strict network of providers and hospitals that you have to stay within. And if you go out of that network, you typically do not have any coverage. Depending on the plan, in some cases, you have to have a referral from your PCP to see specialists. In other cases, you do not. It just depends. But again, if you go out of network with an HMO, you will not have any coverage and all costs would be yours. Then you have your PPO, another term that folks are probably familiar with just from individual and group plans. The PPO is the opposite end of the spectrum from an HMO. This is a plan that's going to provide you a more open network of providers and hospitals. But it's really important to note that while PPO plans allow you to go out of network, you're going to pay a higher cost to do so. So under a lot of Medicare Advantage plans, we see this 45% coinsurance under PPO plans if you go out of network. 45% is a lot more than what you would otherwise pay under original Medicare if you just had a 20% coinsurance. So I caution folks to just select a PPO because they know, oh, well, I can go anywhere if I have a PPO. But if you select a PPO and all of your providers are out of network, you're paying a 45% coinsurance in some cases to go see those providers. You would have been better off just sticking with original Medicare. So it is still really important, even if someone is selecting a PPO plan, that they are looking at their network. What providers can they access? And what's the cost going to be? Even though they can go out of network, if most of your providers are out of network, it's likely not going to be a plan that's going to benefit you. So still really important to look at that. Then you have your private fee-for-service plans. These plans are kind of in the middle. There are specific networks of providers and hospitals, but you may be able to go out of network and pay higher costs if the provider accepts the plan's terms. So it's somewhere between an HMO and a PPO when it comes to restrictions. And then lastly, you have your special needs plans. And these plans are very specific to Medicare. This is typically not a term that folks would hear outside of talking about Medicare. Special needs plans require that you meet certain conditions. It can be that you have a certain health condition, and that's for your chronic care special needs plans. It can be that you live in a certain institution like a nursing home or require nursing home level of care at home, or that you have both Medicare and Medicaid, and those would be your dual special needs plans or DSNPs. So again, special needs plans are always Medicare Advantage plans. And they also always provide your Part D prescription coverage included in them. There is no special needs plan that does not include Part D. Like we had discussed earlier, some Medicare Advantage plans don't, but special needs plans always do. When it comes to the special needs plans for health conditions, it depends on your area, what plans are offered. There can be plans that are specific to COPD, diabetes. There are some plans that are specific to cardiovascular disorders. It just depends on what's available in your area. But in order to select that plan and enroll, you have to meet that specific health condition or requirement. Okay, so I alluded to this earlier, but when it comes to Medicare Advantage and Part D, you will have an explanation of benefits that you typically get monthly that's going to show what was billed on your behalf, what was covered, and what your potential costs are related to those services. Just like with your Medicare summary notice, it's going to be really important that you don't just throw this away. I know when I get something that says this is not a bill, I'm like, whoa, great, I'm going to set that aside, right? Like initially, that's what I want to do. But it's really important that we not do that, especially when we're talking about preventing and detecting healthcare fraud and abuse. This is the best way you can do that. By detecting those mistakes. So making sure that while you understand it's not a bill, it's really important for you to cross-reference, are these services that I actually received, is it accurate? And then what they're saying I might owe, does that match up with what I was billed, right? It's always best to detect that up front rather than pay the wrong thing, do the wrong thing and try to get it back later, right? That's always going to be a little bit harder. So these explanation of benefits are going to be really important for someone with a Medicare Advantage plan or Part D to check out. And unlike the Medicare summary notices, typically these are monthly versus quarterly. Okay, so we've talked about what your Part D and Medicare Advantage coverage looks like as far as the cost and the structure of the coverage. And now we're going to talk about when you can enroll into a plan. So Chelsea mentioned earlier your initial enrollment period. Initial enrollment occurs when someone first turns 65, or if someone's under 65 and receiving SSDI benefits, it occurs once they have received 24 full months of benefits. So if someone is turning 65, their initial enrollment period is 3 months before they turn 65, the month of, and 3 months after. I will note here that if somebody's birthday falls on the first of the month, it's actually pushed up a month. They're actually eligible for coverage the prior month. That's only if their birthday falls on the first of the month. But for most folks, you're looking at the 3 months before your 65th birthday, the month of, and 3 months after. So you have that full 7-month period to not only enroll in your Medicare, but also to select a Part C or Part D plan, depending on what you want. So we always encourage folks to use the 3 months before. That way everything can start the month of. But if someone has other coverage and they're okay with kind of pushing that back, they do have those additional months to get their enrollment done. But as long as you take care of your enrollment in the 3 months before the month of your 65th birthday, everything will start the first day of the month of your 65th birthday. And that's typically the goal for folks who are looking to enroll during their initial enrollment period. Now, for someone who's receiving SSDI, they also have a 7-month period surrounding that 25th month of disability payments. I will note here when it comes to SSDI that there's a standard 5-month wait period. Once someone has been approved for SSDI benefits and eligible, they have 5 months that they have to wait before benefits start. Then once their benefits start, they have to receive benefits for 24 full months before their Medicare kicks in. This is always automatic. They do not need to fill out an application for Medicare. Their card's going to come to them 3 months before their 25th month of disability payments. And then again, they'll have that time to select either a Part C or a Part D plan as they so choose. And then the only exception to this is those folks who are diagnosed with ALS. They do not have to wait that 24-month period of receiving benefits. They are eligible that first month that they get their SSDI benefits. In addition to someone's initial enrollment period, you also can enroll into and change your Part C or Part D plan every year during open enrollment period. Open enrollment period is our busiest time of year. It happens every fall. And this is unlike general enrollment period we talked about earlier for A and B. Open enrollment period is specific to Part C and Part D, and it occurs at a different time of year. If you make changes during open enrollment, which is October 15th through December the 7th, your coverage always starts January 1st. So that's standard if you make a change or enroll during that time. Now, it's also important to note during open enrollment, you can go from Part D to Medicare Advantage. You can go from Medicare Advantage to Part D. You can change Part D or C plans. You really can make any changes between the two during this time. Now, special enrollment periods for Part C and Part D look different than special enrollment periods for A and B. When Chelsea talked about the special enrollment periods for Part A and B earlier, she only talked about 2 because there are only 2 for Part A and Part B. And for most people, there's really only 1 that we're looking at. And that is, do you or your spouse currently work? And do you have coverage based on that current employer or that current employment? If the answer is yes, then you can have a special enrollment period for Part A and B, but only if that's the case. COBRA does not count as employer-based coverage, and either does like any sort of retirement coverage for A and B. It has to be active, current employment-based coverage to get that special enrollment period for Part A and B. That is not the case for Medicare Advantage and Part D. There are a list of special enrollment periods for Medicare Advantage and Part D. There are only 2 special enrollment periods for A and B, okay? So while there is a longer list of special enrollment period opportunities for Part C and D, it does not mean that it's easy to get a special enrollment period. You still have to have some life event that's occurring, or some change or some eligibility. It's still not easy, right? So some of the special enrollment periods for Part C and Part D include if you've moved out of your current coverage area, you do get a special enrollment period for 2 months to change plans in your new area. If you lose current coverage, and that can be employer-based coverage or retiree coverage. It does not have to be employer-based coverage when it comes to Part D and Part C. If you lose some type of creditable coverage or employer-based coverage, retiree coverage, COBRA, you can then enroll into Part D or Part C. If your plan changes its contract with Medicare, if you have a chance to get other coverage, sometimes someone ends up going back to work and they're offered benefits. At that time, they could choose to drop their Part C or D plan, take those benefits that they're being offered, and then later when they lose that coverage, pick up a Part C or Part D plan again. If someone qualifies for low-income subsidy, which is also known as extra help, or Medicaid, they also get special enrollment periods during the year. For that low-income subsidy and Medicaid special enrollment period, you can change Part C or Part D plans once a quarter for the first 3 quarters of the year. This is really important because that means that someone who's eligible for low-income subsidy does not have to wait for open enrollment. Someone who's eligible for Medicaid does not have to wait for open enrollment. You can make that change once a quarter for the first 3 quarters of the year. In the final quarter of the year, you have to use open enrollment period to make those changes. Another important piece here about the low-income subsidy special enrollment period is if someone comes to us and they're either without coverage that they need, or they've lost coverage that they need, or the coverage they have just isn't working for them, we're going to say, hey, let's screen you for low-income subsidy, because even if you don't have it right now, but you're eligible, we can help and complete that application. And if you're approved, that opens a special enrollment period and you don't have to wait, right? So that's something that your local BICAP office would go through with someone if they came during the year and we're looking to need to change plans. We're going to screen for LIS and we're going to complete that application if someone may be eligible. Additionally, if someone is eligible for their state pharmaceutical assistance program, they get a special enrollment period to change plans once during the year. Now, in our state pharmaceutical assistance program, or SPAP, is specific to individuals with HIV or AIDS, but it is different from state to state. Some states have SPAP programs that are just based on income or asset test requirements. So that's different from state to state. But in the state of Virginia, our program is specific to HIV/AIDS. If someone is eligible, though, for that program, they can change plans during the year and they do not have to wait for open enrollment period. Additionally, if there's a chronic care special needs plan that someone's eligible for, so I talked about those special needs plans and how they vary from area to area, but a chronic care special needs plan, someone has to meet a certain health condition requirement to qualify for. So that could be diabetes, that could be COPD, that could be your cardiovascular disorders, etc. If there's a plan available in your area and you qualify, you can enroll into that plan once during the year outside of open enrollment. You do not have to wait. So again, if someone comes to BICAP and is like, hey, I don't have the coverage I need, we're going to look and say, are there any special needs plans in their area? And we're going to say, hey, here's the plans available in your area that you could enroll into if you qualified. Do you have any of the health conditions that would qualify you for enrollment into these plans? It's always worth a look, right? Because if the answer is yes, then you could enroll into that specific plan outside of open enrollment. You do not have to wait. And then additionally, you can enroll into a 5-star plan if one is available in your area outside of open enrollment as well. And in the past, we did not have a 5-star plan available, but now we do. So that's really exciting, right? So if someone comes to us and again, without coverage, has the wrong coverage for them, it's not working, they need a plan, we're going to say, hey, there's this 5-star plan available in our area. And if this plan works for you, we still need to check provider networks. We still need to check prescription needs and things like that. But if it works for you, you can enroll into that plan now. You have that opportunity once during the year outside of open enrollment. And there are other special enrollment periods for Part C and Part D beyond just these, but these are just some of the main ones that we would cover. It's really important if someone finds themselves without the coverage that they need, that they get referred to their local SHIP office wherever they are, because we can go through these opportunities. And again, while it's not like we're just going to be able to pull a special enrollment period out of nowhere for someone, we can screen for these things. And if we need to apply for LIS, we can do that to open up that opportunity. We can look for these chronic care special needs plans. We can look for these 5-star plans. It's always best to do your due diligence and look for these things rather than just assuming that you can't do it. It's always worth the ask, right? And that's what a BICAP office could assist someone with. Now, again, the eligibility criteria and the length of time for all of these special enrollments varies. As I've mentioned, as I've kind of gone through them, some of them are 2 months, some of them are once a year. It just depends. Okay, so in addition to your initial enrollment period, your open enrollment period, and your special enrollment periods, there's also something called Medicare Advantage open enrollment period. And this is really like a second open enrollment period for people who have Medicare Advantage plans, which is really exciting. This was formerly known as Medicare Advantage disenrollment period. It used to be a lot shorter. It didn't go through March. It ended in February, and you were more restricted on what you could do during this period. But now, under Medicare Advantage open enrollment period, it lasts January 1st through March 31st. So you can make changes during that time. It is only for individuals who already have a Medicare Advantage plan as of January 1. So if somebody has enrolled into a Medicare Advantage plan or just maintained their existing Medicare Advantage plan as of January 1st, they now have a whole second open enrollment period. During this time, they could choose to change Advantage plans and pick a different one. They also could choose to switch back to original Medicare and get a Part D plan. Maybe they realized, oh no, under this Advantage plan, I can't go to my hospitals. I can't go to my doctors. I need to get out of this thing. This is an opportunity for someone to do that. Or maybe someone just realized I chose the wrong plan for me. I chose this plan because it had silver sneakers, but I totally forgot that my primary care is out of network. So now I'm going to pick a plan that is still an Advantage plan because that's what I want, but that my providers are in network with, right? So this provides that opportunity. You cannot switch from original Medicare to Medicare Advantage or make any changes to a Part D plan during this time. Again, this is only for someone who already has a Medicare Advantage plan to make changes. Now, just like with Part A and B, if someone goes without this coverage and they were not eligible for a special enrollment period, there is a late enrollment penalty that applies. For Medicare Part D, this penalty applies if you do not have creditable prescription drug coverage and you did not enroll in Part D when you were first eligible to do so. And unfortunately, this happens more than we'd like to see. Oftentimes, what we hear the most is, well, when I first went on Medicare, I didn't take any prescriptions. So I just didn't buy a prescription plan because I didn't need it. And unfortunately, you should not do that. Even if you're taking no prescriptions, go pick up that $7 plan and hold on to it. Because if you don't, then later on, you would be facing a penalty every month for not having had coverage. So you want to have, the coverage that you're eligible for, and you also want to avoid these penalties. The penalty for Part D is 1% of the national base beneficiary premium. And this year, that is $33.37. That changes every year, which means your penalty could change every year. Your penalty could go up. It could also go down based on what that year's national base beneficiary premium is. So 1% of $33.37 this year times the number of full months that you didn't have Part D or creditable coverage and should have. So for every month that you are going without coverage, your penalty is increasing. Now, I will point out here that the penalties can only date back to 2006 when Part D first went into effect. And we certainly have seen folks who had Medicare prior to then and have a penalty dating back that far, unfortunately. But that is the farthest back that the penalties can go because Medicare didn't go into effect until then. But from 2006 on, those penalties do apply. So you pay that penalty, whatever it is, it's rounded up and it's added on to whatever your premium is for the plan that you've chosen. So whether it's a Part D or Part C plan, that additional penalty will just be tacked on to whatever that premium is. And you pay this penalty for as long as you have Medicare. It does not go away. As long as you are enrolled in a Part D drug plan, you're paying this. The only exception to that rule, and it's the same as with the Part B penalty, is if you incurred the penalty before you turn 65, you no longer have to pay that penalty once you turn 65. It does start over at that point. But otherwise, if you are 65 or older, when you incur the penalty, you're paying that penalty forever. So if someone wants to enroll into a Medicare Advantage or Part D drug plan, the great news is, right, that BICAP can help. This is something that we can help you through. But if someone's looking to do that on their own, they have options. You can call the plans directly, you can call Medicare, or you can go on Medicare.gov. And that is the route that we usually go, is utilizing Medicare.gov and the Plan Finder tool on Medicare.gov. If someone comes through BICAP for assistance with selecting or enrolling into Part C or Part D, we're going to use that tool on Medicare.gov to help locate the right plan for you. And then we're going to provide you the information that you need to make an informed decision. BICAP is not here to select a plan and say, this is the one for you. We're here to work through the options and present the information that's needed so that someone can make an informed decision on which plan they want. So when we are looking at plan comparisons, it's always comparing multiple plan options based on what your needs are. So we're going to look at what prescriptions you take. We're going to look at what pharmacies you go to. We're going to look at what providers you go to. If we're looking at Medicare Advantage, and we're going to say, hey, based on your needs, these are the plans that would work for you. And here are the estimated costs related to those plans. Now, with this information, we can assist in answering questions so that you can make an informed decision. And then once someone's ready to enroll into a Part C or Part D plan, BICAP can also assist with that process as well, whether it's walking someone through the steps for them to do it on their own, or actually physically taking the steps to complete that enrollment with someone. Okay, before we move on from Part C and Part D, and we're going to talk about Medigap next, are there any questions? I'm not seeing anything. So I'm going to go ahead and move on. But if any questions come up, feel free to put them in the chat, raise your hand, and there'll be time at the end of the presentation as well to go over questions. Okay, so now we're going to talk about Medicare supplement policies, also known as Medigap. Medigap policies are policies that are provided through private insurance companies to cover the costs left behind by Part A and B. They're covering the gaps in Medicare, right? So we talked earlier about how under Part A, you have a deductible and you have certain co-payments that you are responsible for your inpatient hospital care and for your skilled nursing facility coverage. Under Part B, we talked about how you typically have a 20% coinsurance for your covered services other than for your preventative and screening services. And that can get really expensive, right? So these Medigap policies are created to cover those costs that are typically left behind for you. These are standalone policies, and the premiums for Medigap have to be paid in addition to your Part B and Part D premium. Just like with Medicare Advantage, in order to be eligible for a Medigap plan, you have to have Part A and Part B. So you have to maintain that Part B premium in order to be eligible to have a Medigap policy. Now, when it comes to Part D drug coverage, prior to 2006, when Part D went into effect, there were Medigap plans that included drug coverage. And individuals who had those plans who wanted to were grandfathered in and could keep that coverage. The problem with the drug coverage attached to those old Medigap plans prior to 2006 is that it was not creditable coverage. Those plans had caps in Part D coverage that are very low compared to current drug costs. And so it is not creditable coverage. And we unfortunately see some folks who decided to stay in those plans and were grandfathered in now find that they don't have sufficient coverage to cover their needs. And unfortunately, if someone went without enrolling in Part D, they would incur that late enrollment penalty because that coverage that is attached to those old Medigap plans is not considered creditable. But from 2006 on, Part D is not included in Medigap plans. It cannot be. And so anybody who has Medigap also needs to purchase a separate Part D policy. Again, these plans are not going to cover prescriptions. They're just covering those costs left behind by Part A and Part B. In order for a Medigap to cover, Medicare has to pay first, right? So it has to be a Part A or B covered service, and Medicare has to pay in order for the Medigap to pay. Excuse me, sorry. Okay, so in order to purchase a Medigap policy, there are certain requirements and rules and regulations surrounding this enrollment. So for individuals who are 65 or older, you get a guaranteed right to purchase a plan for 6 months once you are 65 and enrolled into both Part A and Part B. Excuse me. So once you have Part A and Part B and you're 65, that's when that 6 months happens. And that's different for some people, right? Some people are utilizing their initial enrollment period to enroll in Part A and Part B. So that's when their 6 months to enroll in a Medigap would happen. But maybe someone's still working or their spouse is working and they have employer-based coverage. They don't need to take their A and B right now. So they're going to hold off on their A and B enrollment, and maybe later on when they no longer have access to that employer-based coverage, that's when they're going to enroll in A and B. So that will be when their 6 months to enroll into a Medigap starts, right? So it just depends on, excuse me, when you are 65 and first have Part A and Part B. That might be when you turn 65, it might be later. Give me just 1 second. Okay, so for 65 and up, during that guaranteed right to purchase, you have those 6 months. Plans cannot underwrite you and they cannot deny you, but outside of that 6 months, they can. So if you know that at some point in time, you want a supplement plan, you want a Medigap, you need to make that decision when you have this guaranteed right to purchase a plan. So whenever you first are taking your A and B, even if at that time you're healthy and you're like, I'd probably be okay without it. But if you want it in a few years down the road, you better go ahead and get it now because this is your time. For individuals who are under 65, there is no federal requirement for policies to be sold. Now, the state of Virginia did pass legislation that as of January 1st, 2021, any insurance company that's offering Medigap to individuals over 65 has to offer at least one plan to individuals under 65, which is great. The problem is there is nothing right now capping those costs. And so these plans for individuals under 65 are extremely expensive and limited. We're seeing usually just one plan offered for individuals under 65, and it's usually the most limited benefits. And it's at a cost, sometimes 10 times higher than that for someone who's 65 and up. So there's still some work to do there. But in the state of Virginia, individuals under 65 do now have access to Medigap policies. Let's see. Okay, so the cost of Medigap policies are going to vary. The premiums can be rated in 3 ways, and they really do vary widely from plan to plan. This is also something that your local BICAP office can help with when it comes to looking and comparing costs of Medigap policies. The Bureau of Insurance provides a rate guide monthly that they update of the policies being sold in the state, and that provides the estimated premium as well as the coverage details for those plans. So we have access to that information as well as some tools through the state health insurance program website that we're able to access to help someone through this decision of selecting a Medigap policy. Now, as I mentioned, while the premiums vary, they can be rated in 3 ways, and it's really important for someone to understand how their Medigap policy premium is being rated because that's going to determine how their rates increase. I'm so sorry, I cannot get rid of this cough. Give me just 1 second. I'm glad I kept my water close. Okay. So the first way that a Medigap policy can be rated is it can be community rated. There are not many, if any, maybe one community rated plan that I'm aware of in our state right now. They're very few and far between. And a community rated plan, the monthly premium for that policy is the same for all individuals in a coverage area, regardless of age. So premiums might go up based on inflation and other factors, but they are not going to go up based on someone in their specific age. Then you have your issue age rated Medigap policies. And these policies, the premium is based on the age you are when you purchase the policy. So premiums might go up based on inflation and other factors, but they are not going up based on your age. And we do have some issue age rated policies available in our state. And then attained age rated, this is what we see the most of. These policies, your premium is based on your current age. So that means that your premium is going up based on your age as well as inflation and other factors. So that's really important to understand when enrolling into a Medigap policy. Maybe you start around $120, but as you age and as inflation and other factors affect things, that policy is going to increase. Now, there are standard Medigap policies, and this is always the first thing that we look at when someone is wanting to purchase a Medigap. These plans are more expensive than your Medicare Advantage plans. They're also providing the most comprehensive coverage that you can have with Medicare. So while they come at a higher monthly premium cost, you're getting the most comprehensive coverage for your medical services under Medicare. In addition, Medigap policies don't have provider networks. If Medicare pays, the Medigap plan pays. So you can go anywhere that accepts original Medicare and utilize your Medigap. So that provides you with the freedom and flexibility to determine where and how you're going to receive your services because it's based on original Medicare. Now, the standard Medigap plans are all lettered. It starts with Plan A, which is your basic benefits. Your basic benefits include your Part A coinsurance, your Part B coinsurance, your first 3 pints of blood, and your Part A hospice care and coinsurance. So those are your basic benefits, and then it goes up from there. Right now, the most comprehensive plan that's being sold is your Plan G. In addition to those basic benefits, a Plan G is also covering your skilled nursing facility coinsurance, your Part A deductible. That's that deductible that Chelsea talked about earlier that you pay every benefit period. So you could pay that deductible more than once in a year for Part A. It is not an annual deductible. And Plan G covers that for you. Any Part B excess charges that you incur, excess charges are incurred when you go to a provider that contracts with Medicare, but who does not accept Medicare assignment. And you can actually end up with an additional 15% responsibility in those cases. And that would be considered an excess charge. And these plans, or Plan G, is going to cover that for you if you incur it. And it also covers some foreign travel emergency. And then, so you have Plan A, your basic benefits, you have Plan G, which is right now your most comprehensive, and you have everything in between. So when someone's first coming to us and saying, I know I want a Medigap, it's the most comprehensive coverage you can get, we're going to look at this chart first, and we're going to say, okay, how much coverage, right, are you looking for? What do you want? It is important to note that there were 2 other plans that are still out there, Plan C and Plan F, that can no longer be sold to newly Medicare eligible individuals as of January 1st of 2020. But anybody who already had a Plan C or F got to keep the plan. They actually weren't even given an opportunity to get out of it if they wanted to, as far as special enrollment goes. They weren't given any sort of special, opportunity to leave the plan. They were able to stay with the plan, and anybody who was Medicare eligible before January 1st, 2020 can still buy a Plan C or Plan F, but no one newly Medicare eligible as of January 1st, 2020 can buy into a Plan C or Plan F. So the concern there for folks who have those plans, because Plan F was the most comprehensive prior to this change. And that's because it covered everything a Plan G has, and it also covered the Part B deductible. It was put in legislation back in 2015 that the Part B deductible would no longer be able to be covered by Medigap plans, and it just went into effect January 1st, 2020. So this had been coming when we were aware of it. But for folks who have those plans, Plan Fs, the concern is, right, there are very few to no new Medicare beneficiaries enrolling into the plans, and the people that are in the plans are, aging, right? So are those premiums going to skyrocket, right? We don't know the answer to that. But it's certainly a possibility, right, that those plans will become more expensive. So that is something that a lot of people were considering when we were approaching this change was, does it make the most sense to go ahead and get a plan G? Or do we go with the plan F, which at the time was the most comprehensive plan? So those plans are still around. People Medicare eligible before 2020 can still enroll into them, can still maintain them, can still have them. But anybody newly going on Medicare, it's not an option. Okay, so if someone has questions about their Medigap options or enrollment, enrollment with Medigap is done with the plan directly. So unlike Part C and Part D, I told you, you can call Medicare too. For Medigap, if you are enrolling into that plan, it is going to be done with the plan directly. But as always, BICAP can help with that process, right? We have the tools needed to go through the process of gathering information so that someone can make an informed decision on which plan is best for them. What's the premium? How is it rated? How are their benefits structured? How much coverage does someone want, and understanding those things. We have tools to help with all of that. So when we wrap up the Medicare part of this presentation, and we still are going to go into cost saving programs after this, I like to show this graphic just because it seems to kind of help simplify things that we've talked about, because we've talked about a lot, right? You have a lot of options when it comes to Medicare. So you can really take two routes when you're going on Medicare. The first route being you can take original Medicare A and B, and that be your primary coverage. And you can choose to add a Part D drug plan onto that to cover your prescriptions. And then if you want, you can add a supplement plan on top of that to cover your coinsurance and your copays so that you have very comprehensive coverage. On the other side, you could choose to, when you first go on Medicare, take a Medicare Advantage plan. Under these Advantage plans, you still have your A and B. Remember, you're paying that Part B premium, but the Advantage plan is going to take care of all of your coverage. They are going to provide your benefits, and all payments are going to go through that plan. And those plans usually include your Part D in the plan. So those are really your two routes, your two options to Medicare. So the first thing that we're going to do with someone, if they're coming to us and saying, I'm going on Medicare or I'm about to be eligible, what do I do? We're going to make this decision first. How do you want to get your coverage? Do you want to go with original Medicare and look at Part D or supplement plans, or do you want to look at Medicare Advantage plans? It's also important to note as we wrap up this section, as we mentioned earlier with Medicare Advantage, you can change those plans every year during open enrollment period. With Medigap plans, you get guaranteed issued rights to purchase, and outside of that guaranteed issued right, there is no open enrollment for Medigap. If you want to enroll into or change a Medigap plan, you can try to do that anytime during the year. You can be underwritten and you can be denied coverage. That's why it's important to take care of those enrollments and changes during your guaranteed issued right period, if that's what you want, because you could try to make changes anytime. You don't have to wait for open enrollment period to make a change to Medigap, but you could be denied coverage. So what we always tell folks is when you're enrolling into your Medigap plan, enroll into it like this is the plan that you're going to have forever, because in many cases that is the case. You enroll in the Medigap once and you stick with that plan long term. If someone finds themselves wanting a Medigap and they don't have one, or they missed their guaranteed right, you can apply. And in most cases, you're going to go through the underwriting process and see what happens. If someone finds themselves in a Medigap and it's getting too expensive, they're like, I can't afford this. My budget has changed. My income's changed. My, situation has changed where it's just no longer affordable. You can always switch to a Medicare Advantage. You can enroll into a Medicare Advantage plan any year during open enrollment period. So if you have a Part D and a Medigap and you're like, oh, this year, I think I'm going to have to make the switch. During open enrollment period, enroll in that Medicare Advantage plan and make the change. But you cannot always go from Medicare Advantage to Medigap. So if someone's trying to make this decision up front, which route do I want to go? If the concern is long-term, I don't know if I'll be able to maintain the Medigap, know that you can make the switch over to Advantage, but you cannot always make the switch from Advantage to Medigap. So that's something that someone would want to consider when making that decision initially. Okay, before we go into cost-saving programs, do we have any questions about Medigap policies? Okay, I'm not seeing anything. I will still ask one more time at the end of the presentation if you have questions. So if you have anything that you're holding on to, that is certainly okay. Okay, so now we are going to talk about cost-saving programs. The first one we're going to talk about is the low-income subsidy program, which we had mentioned earlier. This program is also known as extra help. Sometimes that's what folks call it, and they'll just say, hey, I have extra help. To some people, that might mean nothing. It's like extra help with what? But to us, that means that you have low-income subsidy. You're getting help with your Part D costs. You do have to meet certain income and resource limits to qualify for extra help. And this is an application that's done with Social Security. BICAP can help with this application process. It's a very easy online application that we can assist someone with. Our Benefits Enrollment Center can also help with this application process here at Senior Connections. So in order to be eligible, in this year in 2022, your income for someone who is single has to be at $20,625 a year or less, with assets at $15,510 or less. You will notice, if you're familiar with other cost-saving programs like Medicaid, this is a lot higher than the income and asset limits for other programs. This is 150% of the federal poverty level and less. For a married couple, the income is $27,705 a year with assets at $30,950. Again, much higher than other cost-saving programs. So in many cases, someone may not be eligible for Medicaid, but they could be eligible for low-income subsidy, which could provide a great benefit. So there are different levels of extra help. You have full extra help and you have partial extra help. Now, when you apply for extra help, you are just applying for the benefit, point blank period, right? You're just putting in the application. Based on what you submit, you will either be approved for full extra help, partial extra help, or nothing at all, right? In order to get full extra help, your income has to be less than or equal to 135% of the federal poverty level. If you receive full extra help, you are going to have a lower premium for your Part D. That premium is going to be lowered by your state's benchmark, which changes every year. This year, the state benchmark is $35.11. So if you have an eligible plan and your premium is $35.11 or less, you will now have no premium because that subsidy is going to cover that in full. If you enroll into a plan that is more than that, you could still pay the difference. But for most people with full extra help, they do not have a premium that they're responsible for when it comes to their Part D. With full extra help, you have no deductible. So if your plan had a deductible, you now have no deductible. And the initial coverage level and coverage gap, you're going to pay either $985 or for brand name medications or $395 for generics. That is a lot less than 25% that you could otherwise pay without extra help, right? We talked about earlier the standard structure. You can pay up to 25% in the initial coverage level and you pay 25% in the coverage gap. So if you get full extra help, your drug costs are being significantly lowered. And then once you get to the catastrophic coverage level, if you do with full extra help, you pay nothing for your drugs. This is the only time with Part D that you're going to get to a point that you pay nothing, right? Is with full extra help. Now, if someone's income falls between 135% and 150% of the federal poverty level, they're going to get partial extra help. Partial extra help lowers your premium by a percentage of the state benchmark. So again, the state benchmark is $35.11. You can get approved for 25%, 50%, or 75% subsidy. And what that percentage means is it's the percentage of the state benchmark that your premium will be reduced by. So if you get partial extra help 50%, it's 50% of $35.11. That's your premium subsidy for your plan. So a lot of times folks get that letter and they're like, what does this percentage mean? And it is directly related to their premium subsidy under partial extra help. So someone with partial extra help is going to have a lower premium determined by what they're eligible for. Their deductible will be $99 or less. So if their plan had a deductible of $480, it's now only $99. If their plan had no deductible, they still have no deductible. So their deductible will just be lowered to no more than $99. During the initial coverage level and coverage gap, someone with partial extra help has a 15% coinsurance for both their brand and generic medications. For someone with partial extra help, 15% is a lot less than 25%, but it doesn't always make it affordable. So some people with this level of extra help still have affordability concerns when it comes to their medications, because 15% can still be too much. But again, much lower than the 25% otherwise. And then if someone gets to the catastrophic coverage level with partial extra help, at that point, they would pay $985 for their brand name medications or $395 for their generics. Now, someone who is full benefit dual eligible meaning that they have both Medicare and Medicaid, they actually get full extra help, but with a slightly enhanced benefit. So they still have their premium reduced by the state benchmark, which is $35.11. They still have no deductible, but their copays are going to be a little less. And the initial coverage level and coverage gap for brand name medications, they're going to pay $4, and for generic, they're going to pay $1.35. So again, a little less than that. And this is just for folks who are dual eligible with an income at or below 100% of the federal poverty level. They have this enhanced benefit. If someone has a Medicare savings program and their income is above 100% of the federal poverty level, they still just have the regular full extra help benefits. It is really important because oftentimes folks may not know what level of assistance they have, and asking the question, how much do you typically pay for your prescriptions? Oh, I pay $1.35 for everything. That's going to tell me not only does this person have full extra help, they have some sort of Medicaid as well, because that is the copay for someone who's dual eligible. So if someone wants to apply for the low income subsidy program, our BICAP offices can do this. And our benefits enrollment center here at Senior Connections can also assist with this. Again, as I mentioned, this application is done with Social Security, and there's a really easy online application that you can go through. It does not require verification documents to be submitted. It is not like the Medicaid application. It typically is very quick. You need to know your income and monies that you may have in bank accounts and investments and things like that. But you're not submitting documents with this. So the application, I would highly recommend to be done online. But if someone cannot do it online, just chooses not to do it with us, which we would be doing it online, you can always contact your Social Security office as well to do this application. It just typically takes longer to do it that way. Okay, now we're going to talk about Medicare savings programs, or MSPs. There are 4 Medicare savings programs that we're going to talk about, but the first 3 are alike in the sense that with these first 3, if you get QMB, SLMB, or QI, we're going to talk about each one, you automatically get extra help. So you do not need to apply for LIS if you already have one of these 3 benefits, or if you have Medicaid, you also automatically get LIS. So someone would not need to apply separately for that if they had those benefits. So the first program that we're going to talk about is the Qualified Medicare Beneficiary Program, or QMB. The QMB program helps cover everything. It covers your Part A and B deductible, copays, and coinsurance. That means that you are paying nothing, right? It's all covered. It is not full Medicaid, okay? With full Medicaid in the state of Virginia, you're going to get other benefits. You're going to have CCC+. You're going to have these other benefits that Medicaid offers. QMB is not full Medicaid, but it's covering everything related to your Medicare covered expenses for you. And in addition, you get that full extra help if you're QMB eligible. So in order to be eligible for this program, your income has to be at or below 100% of the federal poverty level. And there is a $20 a month income disregard included in the numbers here on my screen. And the resource limit for these 3 Medicare savings programs is the same. So it's $8,400 for an individual and $12,600 for a married couple. That is a really important point because for full Medicaid, the asset limit is much more restrictive for somebody who has Medicare. It's either $2,000 or $3,000 for an individual or a couple. So you could potentially fall within income eligibility for full Medicaid, but be out of the resource limit and get QMB because the resource limit is higher. I also want to mention, usually people are calling these Medicare savings programs partial Medicaid. And it can be frustrating because partial Medicaid does not identify the benefit to us, right? You could say you have partial Medicaid and have QMB. And I'm like, great, because you have all of your premiums and deductibles and copays covered. I don't need to worry about talking to you about finding a plan that's going to cap your copays because it's covered. But for example, if you say that you have partial Medicaid and you have the specified low-income Medicare beneficiary program, well, this program only covers your Part B premium. You're still responsible for your copays and coinsurance. And that makes a really big difference when we're looking at what plans are best for you. So just as a general note, typically these programs are referred to as partial Medicaid, but that can be a little frustrating because it doesn't identify what the benefit is. So we really like folks to understand what the benefits are, what the names of the different programs are, so that we can identify, what their benefits are and what they should be looking at when looking at plan options. So again, the specified low-income Medicare beneficiary, SLMB, SLIMB program helps pay for Part B premiums only, which is a great benefit because that money, right, is coming back in someone's Social Security check. And maybe those are groceries for the month. Maybe those are utilities. It's a big deal. And it's always a benefit worth pursuing. But again, it's important in that case to understand that someone would still be responsible for their copays and coinsurance. So we would want to look at plan options with that in mind. In order to be eligible for this program, your income can be up to 120% of the federal poverty level. And again, the resource limit is the same. And then the third Medicare savings program is the QI program, or the qualifying individual program. This program also pays for the Part B premium only, but this program applications are granted on a first come, first served basis with priority to those individuals who received benefits in the previous year. And you always have to apply for the QI program. The income limit is a little bit higher. Your income can be up to 135% of the federal poverty level, but the benefit is the same as the SLMB program, and that is your Part B premium would be paid if you are eligible. Also important to note, when applying for these Medicare savings programs, you are completing the Medicaid application, that medical assistance application for the state. That is what's determining if someone is Medicare savings program eligible. So if someone wants to apply for this, that's the application we're going to complete. And that application should determine is someone eligible for QMB, for SLMB, for QI, or for full Medicaid, right? That determination would come from that application process. Now, the fourth Medicare savings program is different than the rest. It does not automatically qualify you for low-income subsidy. And it's very specific in that it covers the Part A premium. And that should kind of tell you something, right? Because earlier we talked about how the Part A premium, for most people, there is no premium, right? If you have 40 or more quarters, which is 10 years of Medicare taxes paid, or if you're married to someone and are otherwise eligible and they have the required amount of quarters paid, you get Part A premium free. So this program is specifically for individuals who do not. And that is because it's for people who were disabled and working under the age of 65, who lost their premium free Part A when they returned to work, and they're not getting medical assistance from the state to meet the income and resource limit. So they are responsible for their Part A premium at that point. And this qualified disabled working individual program can cover that Part A premium for those folks. So the income limit is high, and it's because it's for someone who's working. It's intended for that. But the resource limit's actually lower than that of the other Medicare savings programs. And the idea is, this is someone who has been disabled and has been unable to work and maybe doesn't have the resources that they need, but they're now working and building that. So this program would then allow the individual to have access to Medicare Part A by covering that premium. Just a note, anytime that we give a presentation and talk about the Medicare savings programs, I always like to cover this because it's so important and we still get calls about it and we hear about it, and it's good for folks to know. Someone who is a qualified Medicare beneficiary cannot be balance billed, meaning that if they go receive services and the provider accepts Medicare and it's a Medicare covered service, their coinsurance and their copays are covered. They cannot be billed the balance regardless of what that provider is being reimbursed. It is illegal for them to do so, and there are consequences for a provider doing that. So folks who are QMB eligible should know that they cannot be charged a copay or a coinsurance for those Medicare covered services. If a provider accepts Medicare and someone is QMB eligible, then they would not be responsible for cost sharing. So again, just an important note here, and we have resources available with this information. If anyone ever feels like they are being balance billed or they don't quite understand what their benefits are and they want to understand this better, that would be a great referral to your local BICAP office. So again, if someone wants to apply for a Medicare savings program, that can be done through here at Senior Connections. We have a benefits enrollment center. And I know Chelsea talked to y'all about that earlier. It's something we launched in 2019, but not every area agency on aging has that, right? Every agency is structured a little bit differently, just like the BICAP offices are structured a little bit differently. So you can, here at Senior Connections, call our benefits enrollment center. But if you're outside of our service area, you'll want to contact your area agency on aging and see what services and options they have when it comes to applying for Medicare savings programs and Medicaid. But your BICAP office can absolutely help you with screening for these benefits, understanding these benefits. If someone wants to apply themselves, you can apply online via the Common Help website. Again, it's the same thing as the Medicaid application. And you can also call or visit your local Department of Social Services to apply for this as well. And that concludes our presentation today. Like I mentioned earlier, I thought we might finish up a little early. It looks like we have about any of the topics that we've covered today. I would be happy at this point to answer those questions. We also have our contact information on this screen. So if you want to refer someone to our BICAP office, we have our own email address for BICAP, which is bicap@youraaa.org. We also have our own intake line for BICAP here at our office, which is 343-3014. Just to note about that number for BICAP, we are volunteer supported. That line always goes to voicemail. So if someone is calling BICAP for help, they have to leave a message and we call everyone back first come, first served. So just know that about that line. But if you have questions for Chelsea or I directly, please feel free to take our email or our phone number and reach out to us. Additionally, I was asked if we could share the slides, and we certainly can.
Absolutely.
So we can have these sent out. I don't know if maybe Sarah or Emily can help with that process of getting those out to everyone, but I'm happy
Heather,
to send them.
if you guys get them to us, we'll get them out, and when we get the recording out as well for everyone.
Awesome.
So
Thank you.
we should have everyone's email on the registration list. If you need them and don't get them in the next week, feel free to reach out directly to me or Emily.
Awesome. Any other questions outside of the slides? Okay.
Great. Well, thank you guys so much for all of that. And thanks for everyone who stuck with us through this great but long and in-depth training. We really appreciate it. And I hope you enjoy the next half hour that you got back of your day. And Chelsea and Heather, you were wonderful. And we really appreciate your time this morning.
Thank you so much.